Hello and welcome to Cardiac Imaging Agora. In this session, we will discuss some clinical and echocardiographic features for the diagnosis of endocarditis. First, every time you're facing with the question of whether a patient has endocarditis or not, these are essential steps before you arrive at the diagnosis. So you always have to start with a history, of course, a physical exam. If you have blood cultures, that's good. If you don't have them, that's something you should obtain as soon as possible, hopefully before you start the patient on antibiotics, or before they arrive to your office and hopefully nobody else started them on antibiotics. Then a series of blood tests that will test for markers for infection, markers for inflammation. An EKG is essential if you're thinking about endocarditis, given the possibility of conduction problems with involvement of conduction structure with endocarditis, a chest X-ray to see if you have any pulmonary involvement, and finally with echocardiograms. So the current criteria for endocarditis goes over a couple of things. First, do we have an underlying anatomy that will favor or will create a milieu in the chest or in the heart that will allow endocarditis to develop and prosper? So first, we have to deal with native valve endocarditis, and usually that's extremely rare unless you have some congenital abnormality or you have a situation with drug abuse. And then prosthetic valve endocarditis, which is now becoming more and more visible with the prevalence of new prosthetic implants, aging population requiring valve replacements, and so on and so forth. The second step is to identify the organism, and this is usually will serve as a basis for the antibiotic therapy and for assessment if you have an invasive species versus just a locally growing species like a fungus infection. And finally, you move on to the echocardiographic, and in this era, the imaging part. In some other videos we have on this website, we discussed the use of CT, and the use of PET scanning, in identifying patients with endocarditis, making the diagnosis, and then identifying high-risk features. So for native valve endocarditis, what are the predisposing conditions? Most of the cases, at least in the Western Hemisphere and in the US, 60% to 80% of non-IV drug abusers have a predisposing condition, meaning they could have a mitral valve prolapse, they could have rheumatic heart disease, degenerative aortic and mitral valve disease, and finally congenital heart disease, which is a minority, but can be overrepresented in the cases of endocarditis because of the high-risk anatomy. Then we move to prosthetic valve endocarditis. That's about 5 to 15% of infective endocarditis. That is rising, again, as I said before, because of the higher prevalence right now of prosthetic valves in an older population. We're more aggressive. We have more options right now, especially with TAVR, to treat these patients, where in the past we've never treated them with aortic valve replacement, and that population has many sources for infection, from UTIs to bed sores, unhealed ulcers, and things like that. And the overall incidence, at least in the literature historically, has been 1 to 4%. The risk is usually high initially and then starts declining after a while. The modern era introduced the concept of endocarditis team. I think this is very important. This is a convergence point in cardiology, at least over the past few years. For all the diseases we manage almost right now, there is a shared decision making, and endocarditis team is one of them. The endocarditis team will focus on many issues. It will focus on the organ involved. If they have any underlying cardiac disease, so this is when some of our congenital colleagues will be involved. ID colleagues here for identification of microorganisms and pathology, and suggestions on treatment with antibiotics. The imaging team is usually working on the presence or absence of complication, and sometimes you need to also involve neurology in these patients because of the question of or the possibility of central embolization to the brain. And finally, the patient characteristics are these patients who are healthy otherwise coming in with endocarditis because of an unfortunate situation, or are these patients who are in a situation where it predisposes them to acquiring endocarditis, such as IVDA, such as nursing home patients. In the modern era, at least in my opinion, a single practitioner will never be able to make all these links and connections, and we need to work as a team to get the best treatment outcomes for our patients. Most of the following slides I'm going to use come from the ESC guidelines in 2015 for endocarditis, and they suggest in it or strongly encourage us to create an endocarditis team in a reference center, especially if you're dealing with complicated endocarditis. So this is an important document. I think you should use it as a reference. And the reason they ask for sending patients to reference centers, because you need to have access to all these imaging tools as well as the subspecialty tools. So on the imaging side, you need to have access to advanced echocardiography, especially with transphageal echocardiography, multi-slice rapid CT scan with proper protocoling for endocarditis, MRI for heart, for the brain, and nuclear imaging, specifically with PET and white blood cell imaging to identify potential occult infections in the heart and outside the heart. Now, the other reason they suggest this kind of involvement with the endocarditis team is to get a good cardiac surgery who are versatile in the management of endocarditis. So cardiac surgery for endocarditis is a totally different ball game than dealing with patients with cardiac surgeons who are used to do bypass surgery and coronary disease. This is a very prolonged, involved surgery that requires often hours and hours of operations with knowing what to deal with when you go in and how to have an exit strategy. And then finally, many subspecialties have to be involved, including something I did not mention earlier, which is probably some of our ID colleagues, especially for pacemaker extractions in cases of right-sided endocarditis and tricuspid involvement. Also interventional neuroradiology for brain aneurysms or pseudoaneurysms caused by septic embolization. Again, to follow up on this concept of endocarditis team, this is something that the patients often not only have to deal with in the hospital, but they have to follow the patient up after they leave the hospital. So very often these patients will come back to see us, they will see the cardiologist, they have to see the infectious disease team. If they have a neurological complication or orthopedic complication with spinal infections, they have to follow up on that. Now we move from these basic foundations of management of endocarditis to more advanced imaging, which is the scope of this website and this talk. We talk about echocardiography. So an essential step in all these patients, beyond the physical exam, beyond the history, beyond the blood culture, is to get a very good surface echocardiogram, at least as a baseline. And if that's not enough, and you're not satisfied with the quality of the echocardiogram, you should start thinking about how to get other things for these patients, such as CT, as we said before, MRI, or even PET with FDG to identify foci of infection that might not be readily seen with other imaging modalities. So the role of imaging, specifically echocardiography. Echocardiography, if done well, and if you're lucky to get all the images, can identify leaflet perforation, rupture of cord D, valve ring abscess in the case of you have a ring, or if you have a full valve replacement. If you have an abscesses or abscess, specifically if you have it in the aortic root, that should be readily seen on echo. If you have effusions, of course, that's also seen on echocardiography. And finally, you can see mechanical complications such as a VSD, such as a fistulation, specifically from the left to right side. Conduction abnormalities usually can be explained by echo if you can see areas of infection, specifically at the base of the heart in the septum, or aneurysms and infections in the sinus of valsalva in cases of aortic root infection. So echocardiography should be able to cover most of these things if you're lucky, again, to get all the images and have a suitable subject that way you can get the proper echocardiographic windows. Now, as far as the ESC guidelines in 2015 versus Duke criteria, Duke is mainly because the points on Duke criteria were derived from echocardiography. So most of what you're going to see on Duke criteria are echocardiographic evidence or echocardiographic suggestions of endocarditis. Whereas the ESC has expanded this, this definition of imaging to not only include echocardiography, but also to include FDG, PET, CT, cardiac CT, and SPECT CT in cases if you decide to do white blood cell imaging. So the differences again between Duke and ESC is the expanded imaging criteria on ESC and the new ESC guidelines. Now, as far as the minor criteria, otherwise they're very similar between the two, between the Duke criteria and the ESC criteria. So again, if we go back to echocardiography, these are the ESC guidelines for this class 1 indication to get an echocardiogram anytime you suspect endocarditis, to move away from the surface echo if you still have a clinical suspicion that's high, to a transesophageal echocardiogram, especially extremely important in patient prosthetic valve endocarditis suspicion. I cannot tell you how often we see patients sent to us where they just had a surface echo and they said, oh, we didn't see endocarditis and the patient has a prosthetic valve. And you'd be surprised how often the surface echo, the transesophageal echo will unmask an endocarditis that's not suspected. And don't be satisfied with one point in time. If the patient is not doing well, you should be able to actually allow yourself to repeat a transesophageal echo or a transthoracic echo down the road, because sometimes you catch the infection, especially in the modern era, very early in the process, so there are no imaging manifestations of endocarditis, but these will develop. This is a progressive disease. These will develop over time, and you might be surprised what you will find on a follow-up exam. Again, you can repeat these exams if there are new murmurs, embolization, persistent fever, heart failure, any deterioration in the clinical scenario or the clinical situation of the patient. Intraoperatively, echo is very good to guide not only the planning for surgery, but also the post-op before you get completely off pump and exit the OR to see if you've fixed most of the problems or all the problems that can be fixed, and you see if they were addressed. And after completing the procedure, you can go on and during the hospitalization or before discharge, follow up these patients, and then we follow them up right before we stop antibiotic therapy at 4 to 6 weeks or whatever the indication or the duration of antibiotic is. Now, in cases where you have Staphylococcus bacteremia, even in the absence of signs of endocarditis, maybe you should consider an echo. Again, this is suggested to do a transesophageal echo in patients where you're thinking about right-sided endocarditis and the surface echo is equivocal or non-diagnostic. Again, you should not be afraid to accelerate or to escalate the therapy or the modality of imaging from a surface echo to a transesophageal echo if you have inadequate imaging or you're not satisfied with the definition of all these problems or mechanical complications we thought about. So again, this is a summary of what I just told you. If you have a prosthetic valve endocarditis, a brief surface echo and move right away to a transesophageal echo. If you have a non-diagnostic transthoracic echo, move to a transesophageal echo. If you have a transthoracic echo that's positive, you can underestimate the mechanical complication or the extent of the disease by that. You should consider strongly going for a transesophageal echo to see if you have other valves that are involved, you have other mechanical complications beyond the valve. That's not something you should just stop at the transthoracic echo. And again, if you have high clinical suspicion, don't stop, just keep on going till you get a full transesophageal echo to make the full diagnosis and the extent and the involvement of the heart. Now, patients with persistent bacteremia, detection of vegetation, valvular dysfunction, shunts, and follow-up to responsive therapy. These are the reasons why echocardiography is extremely helpful in these populations. From the beginning, it will follow the patient till throughout the healing process and the end of therapy. So a good transthoracic echo, we're talking here about native valve endocarditis, a good transthoracic echo where you can see everything. You can actually have a very good specificity to rule out endocarditis. However, where on review, about 30% of transthoracic echoes will fail to visualize all the valves. So in this instance, so about 30% of transthoracic echo, you should escalate and go up to a transphageal echo to make sure you don't have endocarditis. This is native valve endocarditis. Transthoracic echo you should always start with, even if a TEE is planned. In my opinion, you see different structures by different valves, by different procedures, and you don't know if you're going to be able to accomplish and finish the TEE on every patient. You can have worsening of the clinical scenario of the patient. You can have intolerance to the TEE. So you might want to go in, get the images you want to get, and get out. So transthoracic echo is always an essential first step before you go for TEE. And if you find things on TEE, you might actually decide on the planning what you're going to focus on in the transphageal echo. So you can start with the transthoracic echo, identify some pathology, and then go and follow it up and extensively study it with a transphageal echo. Transthoracic echo, again, because it's poor image quality or poor resolution, can be misleading in the first few days of onset of illness, and you should repeat it if needed. When is TEE better? In almost every case. Sensitivity of TEE is in the range of high 90s to 100%, in contrast to about 50% in transthoracic echo. All prosthetic valve endocarditis should be evaluated with the transphageal echo. Detection of abscess by transthoracic echo is very limited to probably less than 1/4 of the patients, whereas in transphageal echo is high up in the 80 to 90% of the patients. And finally, potential for embolization. It's very hard to measure these lesions on a transthoracic echo, and we know that the size of the vegetation correlates very well with the future possibility of embolization. So this is a study that was published a while back, almost 20 years ago right now, to look at the superiority of TEE in addressing endocarditis. The match up between TEE and transthoracic echo is about 50-50, the concordance. Almost 11% of native valve cases were missed by transthoracic echo. Triple that number was missed for prosthetic valve was missed by transthoracic echo. Again, I'm trying to make the case here for you to strongly consider a transphageal echo to rule out the possibility of endocarditis and not be satisfied with a simple transthoracic echo. Limitations of TEE, again, seen here in a table form. Again, you can see here the high diagnostic yield of transphageal echo, talking about 80 to 90% diagnostic yield versus low teens to mid 50s for transthoracic echo, whether it's in the aortic or mitral position. Again, we move along the guidelines of how to diagnose these patients. Again, you can see here the modified DO criteria are the first step because they use a lot of clinical input. And then you can move on with the imaging algorithm here that includes not only echocardiography again, but includes in the modern era a good CT scan. And I then recommend that you listen to the talk on this website by my colleague, Dr. Paul Kremer, highlighting the value of CT and unmasking many cases where echo failed to diagnose the extent of endocarditis. And based on that, you can get the patients into 3 buckets. One is definite endocarditis, possible endocarditis, where you have to follow up the patient with either further imaging downstream or repeat imaging, or the endocarditis diagnosis, the hypothesis is rejected. So 3 buckets here. This is a nice guideline to tell you how to get there. Now, other prognostic markers, in addition to imaging, of course, patients who are older, patients who have comorbidities from renal failure to diabetes, the organism that infects the patient is prognostically important. And some of the mechanical complications we see by echocardiography all are contributors to adverse outcomes in this population. Again, these are available for you on the ESC guidelines. You should refer them. Now, potential for embolization. We take patients with endocarditis, and this is a nice paper, again, from about 20 years ago, looking at the potential for embolization as the vegetation size increases. And you can see here there's this cutoff of about 10 millimeters or so, 1 centimeter, where the risk of embolization exceeds 50%. So this is what we use right now as a cutoff. And that's basically an impetus for sending these patients early to surgery before they suffer an embolic phenomenon. This is a study from 15 years ago in Circ, looking at almost 400 patients who had all confirmed DO criteria for endocarditis, had a full transthoracic, transphageal CT of head, thorax, and abdomen, and they looked at the vegetation size, mobility, and maximum length. Again, you can see here embolization. Distal embolization is not rare, it's about 1 in 3 patients. TTE identified only 52% of the vegetation, so only half and half. So you can have here to actually not accept the transthoracic echo as a risk stratifier for embolization. It misses almost 50% of the cases or the vegetations, whereas transphageal echo identified the majority of these vegetations, and therefore you can actually, before you proceed, or to have at least a gauge of how risky it is for this patient to have a central embolization, which very often is devastating with a stroke or a bleed or a huge neurological sequelae. Again, if you use a different cutoff for this study, they used 15 millimeters versus 10 millimeters in the prior study I showed you. And you can see here, there is almost this, the survival is even affected. So just the size of the vegetation can impact your survival, where patients with more than 15 millimeter size vegetation had a much worse prognosis than patients with under 15 millimeter size vegetation. Echoes also are used routinely now to assess pacer infections, specifically lead vegetation. This is again a growing population because of the increased use of ICD devices, pacemakers in an older population. We're not going to use echo to define whether you have an infection or not, but echo can show you the vegetation on the ICD lead, and you can see involvement of other structures, specifically the tricuspid valve or the pulmonic valve. So is this an isolated lead vegetation where you're going to get away with just extracting the lead and move on and reimplanting another vegetation, another lead in the future? Or is this going to require a surgical explantation of the lead and fixing the tricuspid valve if the tricuspid valve is involved? Obese population, again, patients with Staph aureus, this is a very invasive organism. And finally, if you have a patient with conduction delay, it's a must to follow these patients with echocardiography, with transphageal echocardiography, with CT, with every possible way to identify whether these patients have abscesses that are impinging on the conduction system or infection that's affecting the conduction system. Finally, with all this in mind, I just want to present to you a case of a patient I saw, 33-year-old car mechanic, normal health, with poor dentition, poor teeth, no dental insurance, developed increased weakness, fatigue, sweat. He was presumed to have the flu. He was found by his partner to be somnolent and poorly responsive. Called the EMS team. They came up and intubated him. They transferred him to a local hospital where they drew blood cultures and grew MSSA. He was transferred to our center. This is a transthoracic echo on this patient. You can see here almost a normal looking structures. Maybe you can make up something on the aortic valve in the short axis, but it's not that impressive on the long axis. Then you have here, just by tilting the probe a little bit, you can see the extent of the vegetation here, the involvement of the valve with severe valve regurgitation, probably perforation of that valve, and probably an abscess here posteriorly. So do we need more data? Is this guy a surgical candidate? How long to treat with antibiotics? In the past, that idea was to try to sterilize these patients before you go for surgery. This is an outdated way of treating these patients. It's extremely important to identify these patients early and take them to the OR as early as possible. At our center, we again, as I said before, we send those patients to transphageal echo routinely. This is now the same patient in the OR. You can see now this is the posterior structure is now anterior because of transphageal echo. We're approaching the structures from behind. You can see this very nice abscess at the aortomitral curtain. Right here, you can see prolapse and perforation of the leaflet of the aortic valve. You can see here the massive aortic regurgitation coming back to the left ventricle. here, a disaster, basically a huge mechanical complication related to the endocarditis. Again, you can see here the disruption of the architecture of the valve itself. The patient went for a median sternotomy within a couple of days of presenting here. He had a homograft, which should be the surgery of choice for aortic valve endocarditis, given the resistance of these grafts to infection. He did well. This is post-op images. Again, beautiful images showing complete repair of that infection. There's no involvement of the mitral valve. Everything looks beautiful post-op. The patient was discharged 10 days post-op to a rehab place in Michigan. 2 months later, the patient called us. He's short of breath now with the non-productive cough. He comes here to see me. This is the echo on presentation. And again, the minute you see these patients, you can see this homograft here where you have an elongated LVOT. Usually it's implanted differently. And immediately you can see this disruption of the anterior leaflet of the mitral valve. Here we have this echolucency in it. Right away, again, another mechanical complication, unfortunate for this patient, where you can see a leak from the aortic valve with a jet lesion hitting that area in the mitral valve, over time probably creating a perforation in that leaflet with a leak. So this is a new infection with a new mechanical complication, a different valve than the valve we fixed. Again, extensive mitral regurgitation, severe, torrential, biblical, whatever way you want to say it, mitral regurgitation. This is the transphageal echo on this patient showing disruption again of the mitral valve architecture. Again, the extent of pseudo or an abscess at the base of the anterior leaf to the mitral valve right here. This is the left atrium, left ventricle, right atrium, right ventricle. Again, this abscess structure right here at the base of the mitral valve. Again, you can see it again in this video. Massive abscess at the base of the mitral valve with complete disruption of the leaflet. You can see how big is this hole in the punch hole in the mitral valve anterior leaflet. The regurgitation is massive. Again, you can see it here. Again, TEE is essential for these patients. You can see that in a 3D view, the perforation of the mitral valve. We have 2 perforations that were identified on this mitral valve. Again, this is the report from the transphageal echo. We debated this, discussed this with our ID team, discussed this with our surgeons, with all involved. Finally, we took this patient to the operating room, and this is the result from the operation. These are the observations of the surgeons. There were 2 huge holes, 2 centimeters hole at the base of the anterior of the mitral valve, exactly what we saw on the echo. We reoperated on this patient, aortic valve homograft replacement with another homograft this time, and we put a BioCore valve in the mitral position with a patch of the dome of the left atrium. That whole area was cleaned up and repatched because, again, as I showed you before, the infection did not only involve the valves themselves, that also involved that area or space between the mitral valve, the aortic valve, and the left atrium. Fortunately, he had some complicated post-op course, but after some angioplasty and mechanical thrombectomy of upper venous extremity DVT, we discharged him home to a rehab facility. He came up for follow-up actually 6 weeks later, 3 months later, and then about a year ago, and he's still doing quite well. It's very important, again, as a summary, to understand that this is endocarditis is not a disease that you want to handle alone. This is a disease that requires a full team to identify the organ, the cardiac structure, the microorganism, the central complications, as well as the cardiac complications, and to study the patient characteristics. You should involve all these specialties in the care of these patients, and you should not take it on yourself to just make all the correct decisions. This is, again, a team specialty in the modern era, requiring not basic imaging, but also advanced imaging, and which is, you should rely on your colleagues who know how to read CTs, MRIs, nuclear echoes, advanced echo, and so on and so forth. Thank you, and I hope you enjoyed and learned something from this presentation. We will have more sessions as we go in the future. Thank you.